So I was asked to talk about the issue of going with or against the flow, meaning do we use embolic protection for filters, using filters, or some sort of flow interruption or reversal. And in addressing this, the issue is how do we protect the brain from lesions like this and particulates and other types of material that can perhaps break off during the course of any kind of an endovascular intervention, resulting in an ischemic stroke to the hemispheres. And to do this, I think the initial techniques were really to actually occlude the blood flow, and I'm going to talk about balloon occlusion in a moment. However, the most widely used techniques involve filtration, and these filters, you can see the various numbers of filters. There are more that exist right now, in fact, and various types with a lot of variability, including crossing profile changes, and most importantly, probably pore size and the ability to actually filter any particulate material going to the brain. And in using filters, there's a balance between being able to allow blood flow and capture particles at the same time and protect the brain from significant ischemia. But one thing about all types of filters is that there will be some materials that can, in fact, pass through these filters, and the flow dynamics varies on a device-by-device basis. The first type of protection actually was using this device. It was one of the earlier ones using a balloon on a wire with the idea of protecting the brain using balloon occlusion. And one of the problems with balloon occlusion is that you don't really know what's going on with material on the distal end of the balloon. That is, material could be accumulating blood clot in particular while the balloon is up. When the balloon is deflated, you don't really have control over what's happening on the distal end of the balloon. But the concept was you can get total protection of a brain that can tolerate the ischemia using a balloon, and then do the various intervention, and then employ aspiration techniques. So with balloon occlusion or any type of flow reversal, in fact, flow reversal or proximal occlusion, aspiration is a fairly integral part of the procedure, whereas filtration, aspiration can be used as a safety thing, but it's not necessarily used routinely. And so initial attempts to occlude flow were used primarily in the internal carotid artery. And then for the past number of years, from a commercial point of view, there have been two principal ways of blocking blood flow. One is to achieve common carotid and external carotid occlusion in patients that can tolerate it, so you produce a totally occluded environment. And here you can see the device that used that. It's called a MoMA device. Two balloons. One is placed in the external carotid artery, another one in the origin. And the second one that was pioneered by Perotti and Dr. Schoenholz and his colleagues have done a lot of work in, is taking it to the next step, where in addition to blocking the blood flow, you actually take advantage of the circle of Willis, trying to establishing a reversal of flow, which allows, in theory, kind of total protection while you're working in the cerebrovascular circulation. To do that, however, you have to establish an arteriovenous shunt, and that's generally done at the femoral vein level, and involves an additional catheter and a additional type of procedure, so that once we establish reversal of flow, we can filter it and return the patient's blood. So in theory, it offers the most complete protection, but the question is what happens in actual practice. So finally, with carotid stenting, we've heard about stroke incidents in the previous discussions in general. And there was early work using diffusion-weighted MRI, diffusion-weighted imaging, to try and detect so-called asymptomatic hits to the brain, that is, ischemia to the brain that does not produce a clinical event that can be measured at least with a physical examination. And these early studies seem to show that stenting was associated with asymptomatic changes in the brain, however significant they may have been, compared to carotid endarterectomy. It's also important to know that during carotid endarterectomy, even though in theory there's complete control, either with shunting or other types of techniques, total occlusion, that even with carotid endarterectomy, there's silent injury to the brain that occurs as we work in line with blood flow. So transcranial Doppler is a way of assessing what's going on in the intracranial circulation, and there have been a number of people, including the group again here at MUSC, who have documented, and I think Juan Perotti actually initially emphasized the looking at the various stages of intervention and identifying where the most activity was, so to speak, in terms of hits going on to the brain. And here you can see the varying level of hits, particularly the most being associated with stent deployment in these 3 phases, so to speak, of the various endovascular procedure. Embolization clearly can occur, but hits can be caused by a number of other things, and with the more sophisticated, newer TCD devices, it is possible to separate out artifacts or air or other types of bubbles that could come from contrast or other things from true embolic changes. And it's been identified that stenting is associated with 8 times more microembolic signals, as you see here, than with carotid endarterectomy, which I showed you earlier. So, and looking at this as a measure, we can compare it to distal balloons. And in this first study that was published in 2002, you can see, looking at distal hits associated with balloons compared to no protection at all, that there was a significant reduction in the activity going on inside the brain. With flow reversal, we can actually see this flow reversal occurring, as you can see here in TCD, and generally, and we've actually demonstrated this in a number of live cases, the hit rates are actually markedly reduced in the presence of flow reversal. In this study that was done by the group here, they looked at TCD during carotid stenting and looked at flow reversers versus filters, and using the technique I showed you or mentioned earlier in 15 patients, using filters versus 15 patients with flow reversal. And here you can see the levels of activity that are going on during carotid intervention associated with filters. In this particular case, this happens to be during stent placement. You can see here the abundant amount of activity, and you can see the striking difference with at least flow reversal techniques in terms of the absence of these types of hits. And this was documented in this statistically significant difference when actually quantifying the various levels of hits, comparing flow reversal to use of filter. However, the problem is connecting these events that are seen on TCD with infarcts, not to mention clinical events, and this is still an issue that needs to be resolved. Now, how does that compare to actually clinical events? So if we look what's happening with protection of the brain in these various carotid stent trials, you're going to hear much more about this, but I'm going to focus down here. This is the Empire trial, the flow reversal trial. You can see that there's a general trend, but at least in clinical events, neither the flow reversal nor, in this case, the ARMOR trial, which was recently released, really seemed to show dramatically different changes in the clinical events compared to filter trials, because outcomes of filters have been better. And in fact, if we look at this large cohort of patients in the combination data from the EXACT and CAPTURE-2 trial and look at the outcomes in the principal measures that you see here and compare them to American Heart Association guidelines, you can see that both in symptomatic and asymptomatic patients, that these high-risk registries are actually reaching the goals of low-risk patients produced in these various trials. It's hard to show. I have to show at least one case, and whether you can argue either pro or against filters and embolic protection, but there's clearly a role for both of these in the treatment of patients. This happens to be a patient that has a high-grade ICA lesion, as you can see here, relatively small and tortuous ICA. You can see here contralateral occlusion, irregular common carotid, and so on. And one of the challenges that we have with various types of filters is dealing with tortuous types of vessels, as you see here. And there are occasions where filters just cannot be advanced appropriately or far enough or safe enough and to actually use a filter. And so at the very least, this needs to be part of an armamentarium where we can treat patients without having to worry about filters and manipulation high in the internal carotid artery. So in conclusion, I think there's no clear evidence that flow occlusion or reversal is superior to filters based on clinical outcomes. However, there's a lot of secondary evidence that seems to show these techniques could offer significant clinical benefits. Part of the problems is that our current way of measuring events is so crude, it's basically limited by a neurologic exam. And neurologic exams really only detect very crude neurologic changes. They don't measure high-level executive function or cognitive function or things that could be affected by some of these micro defects that we see both in